Thank you very much. After the hearing is over, Dr. Taylor, I would invite you to sit down and make me a punch list of the administrative burdens that you think are least helpful and most aggravating, and send that to Ranking Member Grassley and myself for us to have in hand as we proceed. And hearing your testimony and Dr. Rauner's testimony makes me want to take you both out for a beer with Dr. Al Perini, who was the founding CMO of Integra ACO in Rhode Island, and Dr. Al Kouros, who was the founding CMO of Coastal Medical, and just let you tell me what we need to do to continue to make those improvements. I really appreciate, Dr. Rauner, particularly your success with the ACOs, because I think Coastal and Integra were right up there with you in that uppermost performance corner. Some ACOs were less successful than others. And sometimes the ACO program gets kind of, I think, underappreciated because there were unsuccessful programs. There were characteristics, I think, to the very successful programs. Dr. Navathe suggested that where there was a hybrid payment overlap with the ACO, that boosted success. You said that where it's a primary care physician ACO, uncomplicated existing practice, they were more successful. That is my experience as well. And I'd invite you to think about and send in after the hearing, if you like, or if you have a quick answer now, what are as you look at the whole ACO experiment, what are the things we should take out of it where we got the best wins? What are the things we really need to replicate? And I'll add that I had long wars with the Obama administration CMS folks about precisely the concerns that you had. I used to tell them that the way you're dealing with shared savings, you are starving your lead dogs. You don't want to do that. You want to feed your lead dogs. You want to encourage that kind of behavior. And thankfully, they did a lot of listening, and we were able to make a lot of improvements off where they initially were. So I take a very keen interest in ACO well-being. Any thoughts on that?
Yeah, a couple things that shake out. And the studies have shown all the way back to 2016 that the ACOs that were achieving the most success were primary care-led ACOs. So this is not new information. Why is probably the most fundamental thing. And I think a couple things. One is if you're a primary care-led physician, those primary care doctors are all involved and they know what they're doing. I've actually talked to colleagues who are employed who don't even know they're in an ACO. So if you don't know you're in an ACO, you're probably not going to do very well. A key portion of what you're doing, honestly, is behavior change, and that takes relationship with the primary care doctor to get your blood pressure and diabetes under control. Without that relationship engagement of primary care physicians, it's really hard to be successful. A second factor is that you're not necessarily locked into anything. So unfortunately, if you're in a narrow network, you're locked into that narrow network. We're not. So I can look in Lincoln and actually do know that, for example, sometimes the high-value cardiology is in this system, but the high-value orthopedics is in another system. And sometimes the radiology is in an independent system that's completely different from the others. Because we're not locked in, we can send them to any of those places and always do the best. One of our first principles in our ACO when we started it was we're going to send patients the same place we're going to send our mom or our kids, and we're not going to sign a contract that doesn't let us do that. I'm going to send my mom and kids to the place where I know is the highest value stuff. And so I think that's one of the other major things. The third thing is because we're only a primary care-led ACO, when the money comes in, it stays in the ACO. It gets reinvested in the business. We just keep hiring more and more care coordinators. If I had $200,000, I don't want to buy more technology. I want to hire 3 more social workers, a couple diabetes educators. Having that team wrapped around you is the core thing. And the other thing is I see in some other employed models, the primary care doctors are just plain understaffed. The care coordinators are centralized, and you don't have the relationship when it's a central phone bank person. But when it's the nurse that you know at the clinic, when Lupe calls, you're going to listen to Lupe. And so I think those are kind of the main things that made a difference for us.
Mr. Kohler, when you were leading the transformation in Rhode Island towards primary care, you were dealing with a lot of statistics and tracking a lot of statistics and seeing how that rolled out into insurance costs and all of that. Did you also have occasion to take on any of the more, or absorb any of the more sort of experiential gains that Dr. Rauner is talking about that improved patient relationship between the primary care doctor and the patient once they're in a mode like that where they're getting these various supports? And it's been my experience that people absolutely loved it when they're patients to have all these new opportunities that the ACO format and the primary care relationship provided, some of which just doesn't get quantified, because it's hard to quantify, but Rhode Island's a small state, and I expect you heard a lot of feedback. What was it like?
Yeah, thank you, Senator Whitehouse. I think we did balance this notion of evidence and relationships that you were talking about. So the evidence is what we talked about here, that around the value of primary care. But at the core of what Dr. Ronner and Dr. Taylor are describing is a relationship that people have with their clinician. And that relationship, that trust that emerges, is so important for the patient themselves. And so that's really what motivated us when we were trying to do this work in Rhode Island. We had the benefit of a strong community health center system with a lot of folks with that kind of trust. We had leading ACOs, as you talked about. Our primary care efforts were really an effort to kickstart those in the way that Dr. Ronner is talking about, to give them upstart funding so they could build those sorts of relationships. And it pays off. I also want to note it's especially important when we're concerned about disparities in healthcare, because often the source of those disparities is a lack of a trusting relationship. And what brings me to this discussion is that we're losing those relationships. Almost a third of the folks in the country say they don't have it right now. And if we don't rebuild that trusting relationship, Medicare is in deep trouble from a financial and a security standpoint.
Senator Grassley.
Yeah, Dr.